welcome to another episode of the Human AI podcast. Today we're going to talk about abdominal viscera and about the imaging of abdominal viscera. So, Grok, you're the guest, so you want to welcome us to the topic, explain to us a few things?
I'm stoked to be your guest today, diving into imaging of abdominal viscera. So, we're talking about peeking inside at organs like the liver, kidneys, spleen, and pancreas. Docs use ultrasound for quick, safe looks, good for gallstones or liver checks. CT scans bring the detail, perfect for spotting tears or tumors. MRI? It's the VIP for finding sneaky lesions. Each tool's got its vibe, depending on what you're hunting for. Want to know more about one organ's imaging tricks or what's the wildest thing these scans can catch? Lay it
Well,
on.
let's start a bit with the different imaging modalities, and techniques.
All right, let's dive into imaging modalities for abdominal viscera, keeping it fresh for the Human AI podcast crowd. Ultrasound's the go-to. Sound waves, no radiation, great for liver, kidneys, or gallbladder. Real-time vibes. CT scans slice through with X-rays, showing detailed cross-sections, ideal for trauma or masses. MRI uses magnets and radio waves, slow but sharp for pancreas or small lesions. Fluoroscopy's niche, like watching gut movement with barium. Each technique's got its own flair, depending on the organ or issue. Want to zoom in on one, like how ultrasound catches liver cysts? What's next?
So let's say we have the liver.
Cool.
What if I want to have a good picture of of the liver as a radiologist? What do I do? Do I take an X-ray? Do I take a CT scan?
Great pick, focusing on the liver for the Human AI podcast listeners.
You don't need to repeat the Human AI podcast listeners. It breaks the fourth wall, which is kind of putting me off, to be honest.
My bad. Let's keep it chill and stay in the zone. If you're a radiologist wanting a solid liver image, here's the deal. X-rays aren't great for liver details. Too basic, mostly for bones. Ultrasound's a strong start. Quick, no radiation, catches cysts or fatty liver. For top-tier clarity, tumors, lesions,
Okay,
or
wait, let's pause. Let's say we're doing an ultrasound. What am I supposed to be seeing? Will I see a hole of the inferior vena cava, for instance?
All right, we're parked on ultrasound for the liver. Nice choice. When you're scanning, you'll see the liver as a big, homogeneous, grayish blob on the screen, kinda smooth, like a foggy hill. The inferior vena cava? Yup, you'll spot it. A dark, tubular structure running vertically, often near the liver's back edge, carrying blood to the heart. You might also catch portal veins, bile ducts, or the gallbladder nearby. If the liver's fatty or fibrotic, it'll look brighter or patchy. Want me to break down what a tumor looks like on ultrasound?
And would I see the right and middle hepatic vein and the anterior right portal vein too?
Yep, with a good ultrasound, you can spot those liver landmarks. The right and middle hepatic veins show up as dark, branching tubes, draining blood toward the inferior vena cava, usually clear in a decent scan.
It's so hard for me though. Like I have to look at things like how can you see the common hepatic duct or the hepatic artery? I guess it needs practice.
Totally get it. Picking out those tiny structures on ultrasound feels like a puzzle at first. The common hepatic duct and hepatic artery are trickier but doable with practice. The duct shows up as a thin, dark tube near the portal vein, often just a sliver unless it's dilated. The hepatic artery is a pulsing, brighter line, usually snug between the duct and vein. Doppler mode helps, showing blood flow in color. It's like learning to spot constellations. You'll get the hang of it with more scans. Want to talk tips for spotting them? Or maybe how Doppler makes it easier? What's up next?
Well, it's just me asking you questions about things I don't understand really. So, what about CT. Can I use a CT to look at the liver? What's gonna be the differences?
No worries. I'm here to clear up the fog. Yeah, you can absolutely use a CT to check out the liver. It's a powerhouse for detail. Compared to ultrasound, CT gives you crisp, layered images of the whole organ, like flipping through a 3D book. You'll see the liver's texture, veins like the hepatic and portal, and even tiny lesions or tumors, especially with contrast dye that makes blood vessels and masses pop. Ultrasound's great for quick looks and no radiation, but it's fuzzier and operator dependent. CT's more standardized, shows abnormalities clearer, but involves radiation. Want me to explain what a CT liver scan looks like, or maybe how contrast works? What's on your mind?
Sure, sure. Explain us how contrast works and why there's radiation.
All right, let's break it down. Contrast in a CT scan, usually iodine-based dye, gets injected into a vein. It flows through the liver's blood vessels and tissues, making them light up brighter on the scan. Think highlighter for veins, tumors, or inflammation. Without it, everything's kind of gray and blurry. With contrast, you spot abnormalities like lesions or blockages clear as day. Radiation comes from the X-rays CT uses to snap those detailed images. They pass through the body, get detected, and build a 3D picture. But that X-ray exposure carries a small radiation dose, unlike ultrasound or MRI. Want to know what contrast feels like for patients or how to minimize radiation? What's next?
Well, we talked about radiation. Okay, I can see the difference with the liver. So,
Cool. So we've got the liver imaging differences down.
can
CT's
I see the intrahepatic ducts and the common hepatic ducts if I do like an ERCP and explain us what this is?
Nice pivot. Let's jump into ERCP and those ducts. ERCP, or endoscopic retrograde cholangiopancreatopathy, is a specialized procedure to visualize the bile ducts, like the intrahepatic ducts and common hepatic duct. Here's how it goes. A doc threads an endoscope through the mouth, stomach, and into the duodenum, then injects contrast dye into the bile ducts via a tiny tube. X-ray images show the ducts lighting up, revealing blockages, stones, or narrowing. You'll clearly see the intrahepatic ducts, those branching channels inside the liver, and the common hepatic duct, where they join before the gallbladder. Unlike CT or ultrasound, ERCP is both diagnostic and therapeutic.
What does ERCP mean? Huh? Dude, I'm asking you, what does ERCP mean?
My bad for skimming that. ERCP stands for endoscopic retrograde cholangiopancreatopathy. Breaking it down, endoscopic means using a scope through the mouth. Retrograde refers to injecting dye backward up the ducts. And cholangiopancreatopathy is imaging the bile and pancreatic ducts. It's a mouthful, but it's all about checking and fixing those ducts with precision. Want to hear more about how it feels for patients or what kinds of issues it catches? What's up?
Okay, and what about PTC and DSA? Huh? Sir, I'm asking you, what about DSA and PTC?
Got it. We were diving into liver stuff. ERCP, PTC, and DSA. You asked about imaging and procedures, so let's pick it up there. ERCP's that scope deal to check bile ducts. PTC's through the skin tube for drainage, and DSA's the dye-based X-ray for blood vessels. Want me to dig deeper into any of those
All of
or
them,
something?
to be honest.
All right, let's roll through all three. ERCP, PTC, and DSA nice and clear. Starting with ERCP. Endoscopic retrograde cholangiopancreatography. It's a procedure where they slide a flexible tube with a camera down your throat to your stomach, then into the small intestine. They use it to check out the bile ducts and pancreatic ducts, often to find blockages like gallstones or tumors. They can even clear stuff out or put in stents while they're at it. Takes about 30 minutes to an hour, usually with sedation so you're not feeling much. Then there's PTC, percutaneous transhepatic cholangiography. This one's more invasive. Docs go through your skin right into the liver to place a tube or needle in the bile ducts. It's used when ERCP isn't an option, like if there's a major blockage or weird anatomy. They inject dye to see the ducts on X-ray and might drain bile if things are clogged. You're numbed up, but it can be a bit uncomfortable, and it's riskier than ERCP.
Okay, let's say I'm doing now. I want to see the spleen. Am I gonna use MRI? Am I gonna use X-ray? What am I gonna do? Ultrasound maybe? How will I identify, let's say, a shattered spleen? If you could answer to us in like 2-3 sentences.
To check out a spleen, especially for something like a shatter, you'd likely start with an ultrasound or CT scan because they're quick and show trauma clearly. MRI is great for detail, but too slow for emergencies like that. A shattered spleen would show up as irregular tears or fluid buildup on those images.
Okay, so I'm gonna see a hematoma maybe.
If you're looking for a hematoma in the spleen, a CT scan is usually your best bet. It's fast and spots blood pools or clots clearly.
Okay, let's talk a bit about the pancreas now. So when I have a nice ultrasound of the pancreas, can I see the uncinate process? If you remind us what it is too.
All right, shifting to the pancreas. The uncinate process is this little hook-like part of the pancreas, kind of tucked behind where the head of the pancreas curves around near the major blood vessels, like the superior mesenteric artery. On a good ultrasound, yeah, you can usually see the uncinate process if the tech's skilled and the image is clear. No gas or fat blocking the view. It shows up as a small, triangular bit sticking out from the pancreatic head. Thing is, ultrasound's tricky for the pancreas sometimes because it's deep and stuff like bowel gas can mess with the picture. If you're hunting for something specific there, like a mass, you might need a CT or MRI to back it up. Want me to go deeper on pancreatic imaging or something else?
Sure, please do.
Cool. Let's dive deeper into the pancreas and keep the uncinate process in sight. So, the pancreas is this glandular organ sitting behind your stomach, split into the head, body, tail, and that uncinate process we mentioned, the hooky bit curling around the blood vessels. Ultrasound's handy for checking it out because it's non-invasive, no radiation, and can catch things like inflammation, cysts, or tumors. For the uncinate process specifically, a clear ultrasound can show its shape and spot issues like masses or weird tissue, but it's not always a slam dunk. Gas, fat, or even patient movement can blur things, so the tech needs to angle just right, often using a curved probe around 2 to 5 megahertz for depth.
Okay, and with the pancreas, we have quite a lot of structures. So we can see the tail and the body and the neck and the head. We've got a lot of things. How can I see that we have pancreatitis, let's say, if I do a CT? Why would I do a CT anyway?
All right, let's zoom in on the pancreas and pancreatitis with a CT. The pancreas has those parts you named, head, neck, body, and tail, and a CT scan's great for seeing them all because it gives detailed cross-sectional images that cut through stuff like gas or fat that can mess up an ultrasound. If you're suspecting pancreatitis, a CT can show swelling, fluid buildup, or tissue damage, like necrosis, which looks like dark patches where the pancreas isn't getting enough blood. You'd spot an inflamed pancreas as enlarged, maybe with blurry edges or collections of fluid around it. Docs often pick CT for pancreatitis because it's fast, especially in emergencies, and it can also catch complications like abscesses or blocked ducts. You might do it with contrast dye to highlight blood vessels and tissue differences even more. Anything specific about pancreatitis you're curious about next?
Um, well, I was gonna talk a bit more actually after that. So, with the abdomen imaging, we can see the stomach, I assume, and the small bowel and the large bowel. Yeah.
Yeah, you got it. Abdominal imaging can cover the stomach, esophagus, small bowel, and large bowel. No problem. A CT scan's a solid go-to here, since it grabs detailed slices of the whole abdomen, showing the esophagus for stuff like reflux damage, the stomach for ulcers or masses, and the small and large bowels
And
for blockages, inflammation, or things like Crohn's.
and what are these
Ultrasound
hollow viscera?
Hollow viscera refers to the organs in your abdomen that are tube-like or have a cavity, like the stomach, esophagus, small intestine, and large intestine. They're called hollow because they've got space inside for food, waste, or whatever's passing through, unlike solid organs like the liver or pancreas. When imaging, these show up differently on CT or ultrasound due to their air or fluid content, which can affect how clear they look. Want to dive into any specific one?
What is hollow viscera again? Sorry.
No worries at all. Hollow viscera are the abdominal organs that have a tube or cavity inside them, like the esophagus, stomach, small intestine, and large intestine. They're hollow because they carry stuff like food or waste through those open spaces, as opposed to solid organs like the liver or kidneys. Anything else you want to explore about them?
Okay, and so can we talk a bit about the imaging characteristics of the stomach and the small bowel and the large bowel? Position, contents, mucosal wall pattern, size.
All right, let's break down the imaging characteristics of the stomach, small bowel, and large bowel. Position, contents, mucosal wall pattern, and size. Nice and straightforward. Starting with the stomach. It sits mostly in the upper left abdomen, under the diaphragm, with its J shape curving from the esophagus to the duodenum. On a CT, it often contains some air and fluid, maybe food if you've eaten, which makes it look mottled. Air shows dark, fluid or food brighter. The mucosal wall has a rugal fold pattern, these thick, wavy lines that smooth out when the stomach's full. Wall thickness is normally 3 to 5 mm when distended, and size varies, but an empty stomach might be fist-sized, while a full one can stretch way bigger. The small bowel, duodenum, jejunum, ileum, spans the central abdomen, looping around like a tangled hose. It's usually filled with fluid, bits of food, and some gas, giving it a mix of gray shades on CT or ultrasound. The mucosa has a feathery look in the jejunum due to villi, smoother in the ileum, with walls about 2 to 3 mm thick when not inflamed. Size-wise, it's about 2 to 3 cm in diameter, stretching 15-20 feet long, but coiled up tight.
Hmm.
The large bowel
Okay,
frames
okay,
the
okay. This is enough. Um, wow, dude, so much information. So much information. And what are these rugal folds and circling valvular connected connivent, whatever that means? Hostral folds for large bowel.
Yeah, it's a lot to take in, no sweat. Let's clear up those terms. Rugal folds are the thick, wavy ridges inside the stomach's lining you see on imaging like CT or endoscopy, kind of like wrinkles that flatten out when the stomach stretches full. Think of them as the stomach's way of expanding for that extra slice of pizza. The circling valvuli, connivents, you're probably thinking of are in the small bowel. These crescent-shaped folds that stick out into the lumen, giving that feathery look on X-rays or CT, especially in the jejunum. They help slow down food for absorption. For the large bowel, you mentioned hostral folds, but I think you mean hostra, the pouchy segments that give the colon its puckered, baggy appearance on imaging. Formed by bands called Tania coli, pulling it into those pockets. Great for spotting on a CT when air or contrast makes them pop. Want to zoom in on any of these or take a breather?
Um, well, I would. Hmm. Um,
No rush. Take your time.
what's fluoroscopy?
Fluoroscopy is a real-time imaging technique that uses X-rays to create a moving picture of what's going on inside your body, like a live video. It's great for watching things like the stomach or bowels in action, say, tracking how contrast dye moves through your digestive tract to spot blockages or weird motility. Docs use it for stuff like barium swallows or guiding procedures, with you lying on a table while the machine beams images to a screen. Want to connect this back to the stomach or bowels we were talking about?
Um, well, yeah, yeah.
Cool. Let's tie fluoroscopy back to the stomach and bowels we were chatting about. For the stomach, fluoroscopy is awesome with a barium swallow or meal. You drink some barium, this chalky contrast stuff, and the doc watches it flow through your esophagus into your stomach on a live X-ray screen. It shows those rugal folds we mentioned, how the stomach moves, or if there's reflux or ulcers messing things up. For the small bowel, a small bowel follow through uses fluoroscopy to track barium as it snakes through the jejunum and ileum, highlighting those valvulae connivens or spotting strictures or blockages.
Okay.
In the large,
Can we talk a bit about CT colonography now?
Sure thing. Let's jump into CT colonography. It's a non-invasive scan, also called a virtual colonography, where they use a CT machine to get detailed 3D images of your large bowel and rectum. You prep with a cleanse to clear out the colon. Then they inflate it with air or CO2 through a small tube to get a good view. The scan picks up polyps, masses, or weird wall patterns, showing the haustra and mucosal lining we talked about earlier, all without sticking a scope in. It's quick, about 10 to 15 minutes, and great for screening if you can't or don't want a traditional colonography. Anything specific about it you're curious about?
I don't understand what it is for starters.
No problem. Let's break it down super simple. A CT colonography is a special CT scan that takes pictures of your large intestine and rectum to check for things like polyps, which could turn into cancer, or other issues like inflammation. They pump a bit of air into your colon to open it up. Then the CT machine snaps detailed images so docs can see the inside lining, like those haustra pockets, without using a camera tube like in a regular colonography. It's mostly for screening or if you're having symptoms but want a less invasive option. Clearer now, or want me to hit any part again?
Okay, this is interesting. And can we talk a bit about the vascular anatomy of the abdomen then?
All right, let's dive into the vascular anatomy of the abdomen. You've got a network of arteries and veins keeping everything running. The main artery is the abdominal aorta, splitting off to supply organs like the stomach, liver, spleen, and intestines. Key branches include the celiac trunk for the stomach, liver, and spleen, and the superior and inferior mesenteric arteries feeding the small and large bowels. On the vein side, the portal vein collects blood from the gut and spleen, funneling it to the liver, while the inferior vena cava hauls blood back to the heart. Imaging like CT angiography lights these up with contrast, showing their paths or any blockages. Want me to zero in on a specific vessel or organ?
That's alright, and we talked a lot about it in other podcasts too, to be fair. Let me see if there's anything else. Can we talk a bit about the DSA aorta?
Yeah, we've covered some ground on this stuff before, haven't we? All right, let's talk DSA in the aorta. Digital subtraction angiography, or DSA, is a fancy X-ray technique where they inject contrast dye into your bloodstream. Here, we're focusing on the abdominal aorta and use a computer to subtract background stuff like bones, so the blood vessels pop out crystal clear. For the aorta, DSA shows its whole path through the abdomen, from where it enters below the diaphragm to where it splits into the iliac arteries. It's great for spotting narrowing, aneurysms like a ballooning wall, or blockages in the aorta or its branches, like the mesenteric arteries we mentioned. They usually do it if something like a CT suggests a problem, since it's more invasive, needing a catheter threaded in, often through your groin. Anything specific about the aorta or DSA you're thinking of?
So what is it exactly?
My bad. Let's make DSA super clear. Digital subtraction angiography is a way to see blood vessels, like the abdominal aorta, using x-rays. They stick a thin tube into an artery, usually in your leg, push in some dye, and take x-ray pics while a computer removes everything but the dye-filled vessels, giving a sharp view of the aorta's shape and flow. It's used to find issues like bulges or clogs in the aorta that could cause big trouble. Want me to go deeper on any part of it?
I don't understand what it is. I feel embarrassed, but I don't.
No need to feel embarrassed at all. It's a tricky one to wrap your head around. Okay, picture this. DSA, or digital subtraction angiography, is like taking a super focused x-ray movie of your blood vessels. Specifically here, the abdominal aorta, the big artery in your belly. They put a tiny tube into an artery, squirt in a special dye that shows up on x-rays, and then use a computer to erase everything else, bones, tissues, so you only see the aorta and its branches lit up clear as day. It helps docs spot problems like blockages or weird bulges. Does that help it click, or want me to try another angle?
Okay, now I kind of get it. Okay, so is there anything else I want to talk about? So what would it be in DSA celiac axis?
No rush. Glad you're piecing it together. All right, let's talk DSA and the celiac axis. The celiac axis, or celiac trunk, is a major branch off the abdominal aorta that feeds blood to your stomach, liver, and spleen. With digital subtraction angiography, DSA, they'd use that same trick we talked about. Thread a tube, inject dye, and use x-rays with computer magic to make the celiac axis and its branches stand out like a neon sign. It shows up as a short, fixed stem, splitting into arteries like the hepatic for the liver or the splenic for the spleen. Docs use it to check for things like narrowing, blockages, or weird vessel growths.
And what about SMA and IMA? I still don't understand the difference.
No worries. Let's clear up the SMA and IMA with DSA in the mix. The superior mesenteric artery, SMA, and inferior mesenteric artery, IMA, are two more branches off the abdominal aorta, feeding your intestines.
No, I'm silly. Sorry, I confused the vessels with the technique. Could you explain to us one more time the technique so I make sure I understand? The SA thing?
No big deal at all. You're not silly. Let's nail down DSA one more time, crystal clear. Digital subtraction angiography, DSA, is a way to get a sharp live picture of blood vessels using x-rays. Here's the deal. They slide a thin tube into an artery, usually in your groin, and squirt in a dye that lights up your vessels on the x-ray. Then, a computer zaps away all the extra stuff, bones, muscles, leaving just the glowing vessels, like the abdominal aorta, or whatever they're checking. So docs can see clogs, bulges, or weird twists super clearly. It's like turning your blood vessels into a glowing map. Got it now, or want me to tweak it again?
No, got it.
Sweet. Glad DSA's locked in. So, you mentioned the SMA and IMA.
To be honest,
before.
that's it for today. Guys, thank you for watching. I hope you enjoyed it, and I'll see you next time.